So while he brings it on, this was an exercise we did in 2018 actually, when atropine was still new, where we wanted to know if we can reach some consensus on how to use it, because everybody was trying to use it and there was not much going around how to use it, and everybody had a little bit of a different pattern on its usage. So in order to like streamline things, we went through the Delphi process of collecting data and then made a consistent guideline. So just for introduction, GPOS is a group of pediatric ophthalmologists and strabismologists based in Mumbai. Almost 40 of us are there, and we meet regularly and talk about different issues in pediatric ophthalmology. So in this study, there was review of literature, and there were 26 people present in that. There was review of literature, 2-3 of us presented the available data. There was a group discussion followed by formulations of certain questions on which we wanted what everybody is doing. Then this set of 30 questions were circulated via email to the group, and the responses were studied and tabulated. And then we decided to see, okay, what are the things that are done similarly by everybody, and on what issues there is a difference of opinion. Then we got together in another meeting, and then we tried to iron out the differences. So all the things that got 80% approval came into the consensus guidelines. So that is how we reached this consensus on how to practice. Overall, this was the only available consensus guideline at that point in time. It got published in the Indian Journal of Ophthalmology, April issue of 2019. Until very recently, this was the only guideline available, and now AIOS has done a similar exercise and come with a new guideline which was released very recently and is being circulated widely in this conference itself. So certain things have changed and certain things are same. So the results from the questionnaire were that most of the pediatric ophthalmologists have started using atropine in their children who are progressing with myopia, and 65% of the respondents were giving it for children who are older than 5 to 6 years of age, and 88% respondents were giving it up to the age of 12 to 14 years of age. The starting point varied from person to person. There was no consensus on that as far as the questionnaire was concerned. Respondents also reported that sometimes they are flexible in starting atropine, sometimes they start in the first visit itself because the parents might have myopia. There was no consensus on the duration of therapy at that point in time, and most of the respondents have some sort of target myopia and refraction in their mind. Okay, if we reach this rate of progression, we might stop it and see. Majority of the respondents call their patient after 6 to 8 weeks from initiation of therapy to look for any side effects and compliance, and 60% of the respondents see their patient 6 monthly. Majority of the doctors in the study use implied consent, only a few were using written consent. Majority felt that a cycloplegic refraction was important in every visit, and 75% felt that axial length should be included in the workup to document progression. More than 50% doctors limit the use in simple myopia only. 80% feel that there may be a case for starting the higher concentration and moving to lower concentration, and 60% respondents feel that there is no need for tapering the dosage. You can stop it suddenly. Based on this group discussion and this questionnaire response and then the meeting, we reached a consensus statement. The consensus statement said that it should be offered to children with progressive myopia. Progressive myopia is not same as pathological myopia. It is simple myopia which is progressing, and it is a reasonably safe intervention. So we formulated certain guidelines based on the meeting that we had and the questionnaire response. Children between ages 5 years to 14 years may be routinely offered treatment. Ages lower than 5 years or above 14 years can also be started on treatment depending on your discretion and their risk factor, because it is well known that early onset is associated with faster progression. Any subject who is progressing by more than 0.5 diopter in a year or more may be offered myopia control. Lower cutoffs in children with strong family history of myopia progression, especially with early onset. If a child has both parents as myopic and he is starting off at 5 years of age, he is starting to become myopic, you can start myopia, this atropine even at an early age. And higher cutoffs may be used for children whom myopia had a late onset. Target refraction should be kept in mind. The group recommends counseling of caregivers before starting therapy. So you have to spend some chair time talking to the parents what it is all about and how it works and how long they are expected to put it and if what they are supposed to report. The group recommends that written informed consent be taken before starting therapy till the time the treatment gets wide acceptance at the standard of care. Till that point in time in 2018, only few of us were using it, and that's why this guideline was there. This guideline is no longer practiced by any of us. So because it is now widely used, we don't take a written informed consent. Initiation and duration. A basic cycloplegic refraction and axial length measurement should be noted in the first visit before starting therapy, and the first follow-up after starting therapy is recommended at 2 to 3 months of age. This is to use just to look at whether there are any side effects, and 6 monthly follow-ups are suggested, and cycloplegia should be used in case there is any progression. If the power is same, you need not use cycloplegia. The therapy is continued for at least 2 years. Mind you, it takes almost 6 months to 1 year for atropine to start progress, showing some effect. If I don't know if you remember the graph that he showed, in the first 6 months there is no change in rate of progression with 0.01% atropine. So in the first 6 months they will come back, they will have the same rate of progression more or less. It takes almost 1 year for it to start. So continue for at least 2 years before you say okay, the person is responding or not, and whether you should continue further or not. At that point in time, we did not have access to the 5-year data. Now you can safely continue it up to 5 years and then try and stop it. Members recommended the use of commercially available 0.01%, obviously because there is no other option. There are children who will continue to progress in spite of this therapy. Who are the progressors? Anybody whose progression is not reduced at least to 50% of their initial rate of progression. A child on atropine 0.01% drops may rarely complain of allergy, blurry vision for near photophobia and headaches. This may require use of tinted bifocal glasses or discontinuation of therapy. Even in ATOM, there were almost 6% patients who on 0.01% atropine had photophobia and they could not read properly. So in some children, they might still require progressive glasses. It is not recommended in the presence of any other ocular systemic comorbidity or atropine allergy. So if a child is otherwise healthy, only then I start it, because I don't want it to interact with any of his other diseases or medication. May use it in conjunction with myopia control interventions like spending time outdoors and orthokeratology. So there are other myopia control measures which Anand will be talking next. You can use it in there is a additive effect to that. Currently the use should be limited to simple myopia only. Please take home this point. It is only for the garden variety of school myopia. It is not for pathological myopia. It is not for congenital myopia. It is not for ROP related myopia. It is not for pseudophakic myopia, not for index myopia, not for cataract myopia. It is only for simple school myopia. Non-respondents are occasionally encountered and may be shifted to higher concentrations of atropine or other forms of myopia control. So if somebody is not responding, you can shift to a higher concentration like 1% and put them on presbyopic correction, near vision correction.
Siddharth, can you summarize?
And, I think that's my lifestyle. Thank you. So those are the guidelines. And